Welcome to the Deep Dive, the show where we take the densest material in your syllabus, the kind you usually skim the night before an exam, and we transform it into the knowledge anchors you really need to excel on the wards.
Today we are undertaking a deep dive into what is, well, arguably the most fundamental challenge in modern healthcare, aging and disease, drawn from Chapter 34 of Davidson's Medicine.
And our mission today is absolutely essential. We need to take this really complex, often overwhelming content on geriatric care, things like frailty, multimorbidity, atypical presentations, and just distill it into highly memorable, critically important concepts. For those of you just beginning your clinical journey, this field isn't some specialty elective. It is the core practice of medicine now. You will spend the vast majority of your time caring for older adults.
And that demands a complete paradigm shift. Our source material, anchored in the latest edition of Davidson's, gives us the perfect framework for that shift. We aren't just looking at a single disease in isolation. We have to integrate the person's entire context, their functional capacity, their frailty state, their social support, and of course, their burden of multiple chronic illnesses.
So when we talk about shifting perspective, I think the most immediate conceptual hurdle for new students is just getting past the calendar. The chapter is so clear that geriatric medicine fundamentally requires focusing on biological age over chronological age. But why? Why can't we just look at their birth certificate?
Well, it really comes down to this massive individual variability. I mean, you might have one patient who is chronologically 85 but is robust. Maybe they're completing triathlons.
Yeah.
And then your next patient is chronologically 68 but is severely limited by heart failure, renal impairment, disabling arthritis. Chronological age tells you almost nothing about that person's physiological resilience.
I see.
Biological age, on the other hand, reflects the true capacity of their organ systems and, critically, their remaining reserve.
So our job, then, is to figure out where that patient lies on the spectrum of biological aging, regardless of what's on their ID. Our entire assessment and management strategy has to pivot away from the age on paper and toward these other factors, like frailty, disability, and multimorbidity.
Exactly. We are assessing the context in which the disease occurs.
Okay, let's unpack the sheer magnitude of this demographic reality first, because the numbers are, well, they're staggering, and they really inform everything we do clinically. The sources highlight that in places like the UK, the population over 65 grew by 24% over 30 years.
While the general population grew by barely 11%.
And that's a huge difference.
It is. And crucially, if you drill down into that data, the steepest, fastest growth is in the segment we find most challenging clinically. Those over 80, they're the ones with the highest multimorbidity and frailty rates.
So this isn't some slow societal trend we're talking about.
No, not at all. It's a rapid, profound structural shift that impacts everything, from the physical layout of our hospitals to the staffing of community services.
This shift immediately introduces the concept of the old age dependency ratio. Now, this is often framed purely as an economic problem, right?
It is. The definition is simple. It's the ratio comparing the number of people of working age to those over retirement age.
Okay.
When that ratio increases, meaning fewer workers supporting more retirees, it naturally creates a massive financial strain on pension systems and Social Security. The sources are very upfront about this far-reaching consequence.
But I appreciate the nuance the authors bring in because they push back against this idea that older people are solely a burden.
Absolutely. We have to remember the human factor here. While the financial mechanics are strained, the sources are careful to remind us that a significant percentage of older people actively support the economy and society in other ways.
Like what specifically?
While they often provide invaluable informal care, like childcare for their grandchildren, which enables younger adults to remain in the workforce, or they might be caring for their own, even older relatives. So their contribution remains vital, even as the formal financial structure strains.
The cost we do see rise sharply, though, is the disability burden. We talked earlier about biological age, and this data brings it into such sharp focus. It feels like we've extended life, but not necessarily maximized the quality of those later years.
The figures are truly sobering, and they define the clinical reality you're going to face. The prevalence of chronic illness or disability enough to restrict daily activities rises from about a quarter in the middle-aged population to a staggering 66% of men and 75% of women aged over 85.
Wow.
So the goal of medicine is shifting from merely extending years of life to increasing the number of healthy, functional years, what we call health span.
So for us in training, the key takeaway isn't just a political or economic problem. It's a deeply practical one about how our systems need to be designed.
Exactly. And population aging isn't unique to industrialized nations, it's rapid and global. The sources note that in developing countries, the rate of increase in the elderly population is often twice as fast as the general population growth.
Which means they have even less time to adapt.
Precisely. This requires rapid and massive adjustments in healthcare system organization, prioritizing preventative care, chronic disease management, and integrated community services that can cope with this exploding need for complex care outside of acute hospitals.
Okay, let's pivot now to the microscopic level and really understand why we age biologically.
Right. So Davidson defines aging at its root as the progressive accumulation of random molecular defects. Despite the incredibly robust cellular repair mechanisms we possess, these defects they accumulate relentlessly over the life course.
And eventually, they lead to functional impairment.
Exactly, across all our tissues and organs.
When we talk about lifespan, there's always this question of destiny versus choice, nature versus nurture. We know genetics plays a role, but the sources seem to downplay that role pretty significantly.
They do, and it's a critical message for the clinician because it means you have agency here. Genetic factors account for only around 25% of the variance in human lifespan.
Only 25%.
Which means 3/4 of your patient's trajectory is determined by lifestyle and environmental factors. This should be empowering. It means intervention, even late in life, can make a difference.
So stopping smoking at 60 is still hugely beneficial.
Hugely, because that genetic component isn't the dominant driver.
Let's talk about the specific damage. If we use this metaphor of molecular wear and tear, where exactly is the cellular machinery breaking down? What are the, say, 4 key areas of structural damage we need to anchor in our minds?
Okay, think of it as a 4-pronged attack on the core components of the cell. First, you have the nuclear chromosomal DNA.
The master blueprint.
Exactly. Damage here involves the accumulation of mutations and deletions. The most feared outcome is, of course, the increased risk of malignancy.
Right, cancer.
But it also just compromises the cell's ability to operate correctly on a day-to-day basis.
Okay, so that's number 1. What's next?
Second, telomeres. Think of these as the protective plastic tips on the ends of shoelaces, but for our chromosomes. They act as the literal biological clock. With every single cell division, they get a little bit shorter, and when they become critically short, the cell enters senescence and replication just stops.
Which is a good thing for preventing runaway cancer growth, I suppose.
It is, but it also limits our capacity for tissue renewal. It means less effective healing and repair as we age.
Okay, so we've got DNA in the biological clock. What's the third area?
Third is the mitochondrial DNA, or mtDNA. Mitochondria are the cell's energy plants.
The powerhouses.
The powerhouses. Damage to their DNA results in reduced efficiency and less production of ATP. Reduced cellular energy is catastrophic. It means reduced performance across all organ systems, from a pumping heart cell to a filtering nephron. This often leads to programmed cell death or apoptosis.
And the fourth prong of this attack?
Proteins. These are the cell's structural beams and functional enzymes. They get damaged by processes like non-enzymatic glycosylation, where sugars just spontaneously stick to them.
So what does that look like in practice?
Imagine structural collagen or flexible elastin becoming stiff, brittle, and dysfunctional. This contributes significantly to the visible signs of aging, like skin inelasticity and vessel stiffness.
So the cell is simultaneously losing its blueprint, hitting its replication limit, running out of fuel, and having its structural supports corrupted. And mediating all this chaos is this systemic issue of chronic low-grade inflammation.
That's the compounding factor that turns all this localized damage into systemic vulnerability. We call it inflammaging. The sources emphasize the generation of reactive oxygen species, or ROS, these unstable oxygen molecules that cause oxidative damage. And while our bodies have antioxidant defenses, chronic exposure from pollution, poor diet, smoking seconds, it just overwhelms these systems. This persistent low-grade inflammatory state is what connects the microscopic defects to the macroscopic clinical frailty we see on the wards.
Let's pivot now from that biology to its expression at the organ level. This is where we introduce probably the most crucial physiological concept of the day, reduced reserve capacity.
This is the concept that must burn into every student's memory. We can illustrate it using the empty fuel tank metaphor. Physiological changes due to age alone, without coexisting disease, usually maintain normal organ function at rest.
So you're fine just sitting there.
You're fine at 1,000 feet. But aging drastically depletes your reserve capacity. It empties the fuel tank you need to climb to 10,000 feet or deal with an emergency.
And that's the clinical difference, isn't it? Between a robust 30-year-old and a frail 80-year-old facing the exact same stressor, like a massive dehydration event or a severe infection.
Precisely. The young person has, say, 90% reserve capacity. The older person might only have 10%. A younger, robust patient can handle that stressor by dipping into their substantial physiological buffer.
Whereas the older adult,
Whose fuel tank is already near empty experiences that same minor illness, a simple urinary tract infection, and it instantly causes acute organ failure in systems that were previously just about compensating. That's what leads to delirium, acute kidney injury, or heart failure.
so we need to understand the specific system losses that contribute to this. Starting high up, the respiratory system. What is aging taking away, and what's the clinical cost?
The lung tissue itself loses elasticity, the chest wall becomes more rigid, so it requires more energy just to breathe. And crucially, the protective reflexes diminish. Reduced cough strength and reduced ciliary action.
So the cost is?
The cost is reduced vital capacity, meaning less available oxygenation during stress, and a significantly increased risk of infection pneumonia because they simply cannot clear mucus and pathogens effectively.
Okay, moving to the cardiovascular system. What are the changes that predispose them to instability?
The maximum heart rate achievable during exertion drops significantly. The major arteries lose elasticity, which increases vascular stiffness. And within the heart itself, there's fibrosis and a loss of pacing cells in the conduction system.
Which leads to what clinically?
A major reduction in exercise tolerance, a widened pulse pressure, and high risk of developing common rhythm abnormalities like atrial fibrillation. And on top of that, stiff vessels mean they struggle to adapt to rapid positional changes, hugely amplifying the risk of postural hypotension and, of course, subsequent falls.
And the central systems, CNS and muscle, this loss is so visible clinically.
It is. We see a measurable loss of neurons, especially in the cortex, which translates to slowed information processing and reaction times. But look at the muscle. There is a specific and crucial loss of type 2 fast-twitch muscle fibers.
And those are the ones for quick movements?
Exactly. They're essential for sudden corrective movements, stopping a stumble or catching yourself when you lose balance. Their loss, combined with slowed CNS reaction times and decreased position sense, results in generalized weakness and a massive increase in the risk and frequency of falls. We also see common sensory losses like presbyacusis and presbyopia.
Hearing and vision loss, yeah. And finally, the renal system. This is the one that directly complicates all of our prescribing decisions.
Absolutely vital. Aging results in progressive nephron loss and a resultant reduction in glomerular filtration rate, the GFR. Now, serum creatinine may remain deceptively normal because of decreased muscle mass, but the GFR is low.
And clinical impact.
It means impaired fluid balance. They are incredibly vulnerable to both dehydration and overload, and, most importantly, severely impaired drug metabolism and excretion. We have to adjust almost every single medication we give based on their estimated renal function.
That inventory, that physiological baseline, is the foundation. If you're listening to this right now, I want you to mentally check these systems. Can you immediately name one consequence of reduced reserve capacity in the musculoskeletal system and one in the renal system? If you can't, I strongly urge you to just pause and quickly review that empty fuel tank section, because those specific losses are the actual mechanisms of frailty.
Okay, so now we move to the clinical concepts that define the context of the older patient. We need to clearly distinguish the big three: multimorbidity, disability, and frailty. They often overlap, but understanding their differences is absolutely essential for targeting management.
Let's start with multimorbidity, as it's the easiest to count, though maybe the least descriptive of a person's vulnerability.
Right. Multimorbidity is simply the presence of multiple chronic health conditions in one individual, like having COPD, type 2 diabetes, and mild cognitive impairment all at once.
Which is pretty common.
It's almost universal in the oldest populations. And it's the primary driver of complexity, multiple doctors, and critically polypharmacy. But here's the key distinction. You can have a robust 70-year-old with 3 well-controlled chronic diseases who is highly functional.
So multimorbidity drives complexity, but it doesn't necessarily mean vulnerability.
Exactly. Now, next is disability. This is established loss of function.
So it's the functional consequence of disease.
It is. It's the established loss of ability resulting from complex interactions between health problems and the environment. To truly understand disability, we rely on the WHO International Classification of Functioning, Disability, and Health Framework, the ICF.
We introduced the ICF briefly before, but let's slow down and give the listener time to digest its 3 levels, because this really dictates our rehabilitation goals, doesn't it?
It does. The ICF describes function loss at 3 interlocking levels. Let's think of a patient recovering from a stroke.
Okay.
First, you have impairment. This is the problem in the body structure or function, the disease process itself. For the stroke patient, this would be hemiparesis or muscle weakness.
Right, the physical deficit.
Then there's activity limitation. This is the difficulty in performing a standard activity of daily living. Because of the hemiparesis, the patient can't walk unassisted or dress themselves.
And the 3rd level.
Societal participation restriction.
Yep.
This is the inability to fulfill desired life roles. The patient can no longer attend their weekly golf league or volunteer at the community center.
That's helpful.
Yeah.
So disability isn't just a physical problem. It's a social problem, defined by that failure to participate. Which brings us to the core vulnerability, frailty.
Frailty is fundamentally about risk. It is the state of increased vulnerability to adverse outcomes, like falls, hospitalization, or death, because of severely reduced physiological reserve across multiple systems. Frailty is the susceptibility to function loss. Disability is the function loss itself.
So if a patient has a severe stroke, they acquire a disability, the paralysis, but they might not necessarily be frail if they were otherwise robust.
Exactly.
But if they were already frail, that same stroke is much more likely to cause irreversible dependency.
That's the critical distinction. Let's reinforce this with the tolerant bridge metaphor from figure 34.2. The image is so clear. A robust person has a high functional baseline. A minor stressor bout of influenza causes a small, acute dip in function.
But they bounce back.
They have the reserve to recover rapidly and fully. The bridge is tolerant. The frail person, however,
Is walking near the edge of the cliff already.
they are. The frail person starts at a low functional baseline because of that depleted reserve. That same minor flu causes a catastrophic massive dip. The resulting loss of function is often irreversible or requires intensive rehab to recover even partially. They frequently stabilize at a lower baseline, shifting permanently toward dependency.
The bridge breaks under even minor stress.
It does.
So how do we grade this vulnerability?
Yeah.
We use several methods, but the most practical clinical tool is the Clinical Frailty Scale, or CFS.
The CFS is excellent because it relies on clinical judgment and observed function. It goes from 1, very fit, to 9, terminally ill. You really need to know the mid-range categories.
Okay, what are they?
So category 4, vulnerable. These people aren't fully dependent, but they are slowed up or tired during routine activities. This is your warning sign.
Got it.
Category 5, mildly frail. They start needing help with higher order tasks like managing finances or preparing meals, what we call instrumental ADLs.
And category 6.
Category 6, moderately frail. This is where dependency really hits hard. They need help with all outside activities, housework, and usually require at least minimal assistance with basic tasks like bathing or dressing.
And the scale's usefulness extends to patients with cognitive issues too, right?
Yes, the source clearly links the CFS score to dementia severity. A patient scoring a 6 or 7 on the CFS is often experiencing moderate to severe dementia, requiring complete dependence for daily living. This emphasizes that frailty is physical, mental, and social all at once.
So we know the concepts: frailty is vulnerability, disability is established loss. Now, the assessment. How do we take a history and conduct an examination that captures all these dimensions rather than just chasing the acute cough or pain?
Well, the process starts with the environment and pace. You need to find a quiet area, make sure sensory aids like glasses and hearing aids are being used, and you have to slow down. A detailed systematic inquiry is non-negotiable because presentations are so often atypical. You have to look for problems the patient isn't complaining about.
What are the 3 non-standard history components we absolutely must prioritize in geriatrics?
First, establish patient goals. What does this person value right now? Is it longevity? Is it symptom control? Or is it functional independence? A 95-year-old may prioritize not having frequent blood tests over strict guideline-driven cholesterol control. This dialogue guides everything.
Okay, that's number 1. Second,
A detailed medication history. And I don't just mean what they are prescribed, but what they actually take, their adherence rates, any supplements. The medications are so frequently the cause of the problem's so-called iatrogenic disease.
and the third, the real cornerstone of identifying acute illness.
Establish usual function. You must know their baseline mobility, continence, cognition, and self-care capacity. A sudden acute change in function is often the first and only reliable sign of acute illness in a frail adult. If they were managing their own medications a week ago and now they can't, that's your red flag. regardless of the lab results.
And crucially, we can't rely solely on the patient if we suspect cognitive impairment or acute delirium.
No, we need collateral history. Information from a family member, a caregiver, or their GP is essential to establish that premorbid baseline. And furthermore, we must explicitly inquire about caregiver stress. An overstressed, burnt-out caregiver is a major risk factor for institutionalization or neglect of the patient. Supporting the caregiver is part of supporting the patient.
Finally, the history has to integrate social factors, the environment that enables or restricts their activity.
The social assessment is foundational. What are the home circumstances? Are there stairs? Is there adequate heating? Are there safety rails? Then we formally assess activities of daily living, or ADL.
And this is broken down, right?
Yes, into basic ADL, which are self-care tasks, bathing, dressing, toileting, walking, feeding. Loss of basic ADL capability usually signals severe disability or frailty.
And the other type?
Extended or instrumental ADL. These are tasks necessary for independent living, shopping, using the phone, managing finances, cooking, housework. These are the first to go when that reserve capacity drops.
Okay, moving to the physical examination. If the patient is frail, they may not tolerate a standard prolonged exam. How do we have to tailor our approach?
It must be thorough and systematic, but highly sensitive to stamina. You might need to examine the cardiovascular system in the morning and the musculoskeletal system in the afternoon. The focus shifts heavily toward risk assessment, looking for early pressure sores, assessing fall risk, and screening for hidden dehydration.
Let's review that source checklist of specific geriatric exam points. Which systems demand that heightened attention?
Well, you're looking for signs of volume and nutrition deficits. For hydration, check mucous membranes, look for sacral or postural edema. For nutrition, BMI can be misleading, so document any recent unintentional weight loss. Look inside the oral cavity for poor dentition or candida, which can really affect nutritional intake. For cardiovascular, check the pulse for irregularity, for AF. And again, always perform that structured postural hypotension check. And for skin, do a meticulous check for early pressure sores, especially over the sacrum and heels.
And you can't forget the basics.
Never. Palpate for bladder distension for retention, and perform an anorectal exam if constipation is suspected, as impaction is a major delirium precipitant.
We also have to rely on standardized screening tools to quantify some of these risks. Let's detail the 3 most practical tools for the clinical setting.
First, cognitive screening. Ensure sensory aids are maximized. If the patient is acutely unwell, use the 4A test, or 4AT, which is designed to quickly screen for delirium. If they're stable but you suspect chronic cognitive decline, the MOCA is a good tool.
And always with collateral history.
Always. Use structured collateral questionnaires like the 88 interview with a caregiver to separate chronic decline from acute change.
Second, the definitive method for postural hypotension assessment. It has to be done manually and systematically.
The protocol is strict because reliability is key. First, they lie supine for 5 minutes. You measure their BQ and heart rate. Then they stand up rapidly. You measure their standing BP and heart rate immediately and then repeat it at 1, 2, and 3 minutes. A positive result is a fall of more than 20 mmHg systolic or more than 10 mmHg diastolic.
Got it. And the third tool, the quick functional safety check. The get up and go test.
This test requires the patient to stand up without using their arms, walk 3 meters, turn, return to the chair, and sit down. Now, the timing matters, under 12 seconds is normal, but the sources are clear that observed performance is more critical than the clock.
What are you looking for?
You watch for unsteadiness on rising, which suggests proximal muscle weakness, unsteadiness on turning, which suggests a balance deficit, or difficulty sitting, which suggests weakness or ataxia. These observations just scream fall risk.
Before we move into management, I really want to emphasize that history requirement again. It is foundational. When you're faced with a patient who has fallen, you must ask the question that reveals their baseline. If you skip that step, your diagnosis will be flawed. Think about how essential establishing that usual function is. It separates frailty from robust independence and acute illness from chronic decline. It's the single most important piece of non-acute information you need.
So we've established that managing the older adult is complex. The subsequent management approach has to be equally holistic, and this brings us to the Comprehensive Geriatric Assessment, or CGA.
What's the key thing to remember about CGA?
The key is in the definition. CGA is not just a one-off assessment tool. It is a dynamic, iterative process carried out by an MDT focused on identifying and managing all the interwoven factors affecting the older person's health, medical, psychological, functional, and social.
Let's use the MDT pit stop metaphor again. It's not just the doctor checking the engine, it's the entire crew working simultaneously on the whole car.
That's a great analogy. The resulting plan is goal-driven and holistic, and it addresses 4 core elements of the patient.
Which are?
1, their medical complexity. 2, their functional status and ability. 3, their mental health and cognition. And 4, their support networks and care needs.
And we know this works. The evidence isn't hypothetical, it's historical.
It goes back to Dr. Marjorie Warren's pioneering work. Systematic reviews confirm that CGA, when it's properly executed by a dedicated, integrated MDT on a specialist unit, reduces the likelihood of death or deterioration and significantly increases the chance of the patient returning home and living independently.
A major outcome of CGA is often rehabilitation. How should we define rehabilitation goals in this context?
Rehabilitation is a holistic process aimed at improving the ability of the patient to perform activities that are important to them. It is inherently functional and task-oriented.
And the success really hinges on the integrated work of the MDT. What's the biggest misconception students have about the role of, say, an occupational therapist versus a physiotherapist in rehab?
That's a great practical question. Students often conflate the two, but their roles are distinct and complementary. The physiotherapist, or physio, their focus is on mobility, muscle strength, balance, and gait. They get the patient moving safely.
Okay, and the OT?
The occupational therapist, the OT, their focus is on activities of daily living, ADL, and especially the interface with the home environment. They assess if the patient can manage their own kitchen, toilet, or stairs, and they organize the necessary adaptive equipment and home modifications.
And what about the other key roles?
Well, the social worker manages complex care needs and discharge pathways. The speech and language therapist handles swallowing and communication. The dietitian ensures adequate nutrition for recovery. And the nurse often leads on self-care and continence. It's a unified front.
The process itself relies heavily on goal setting, right?
Yes. After the comprehensive assessment, the team sets goals, and these must be specific, realistic, and agreed upon with the patient. The intervention is then task-oriented, and reassessment is continuous to measure progress against those functional, agreed-upon goals.
Okay, this brings us back to the guiding philosophy of it all.
Exactly. Old age alone should never be a reason to withhold treatment, and conversely, functional decline should never be accepted as just aging without a thorough search for a treatable cause. We must always investigate a change in status.
But applying standard guidelines can be really dangerous in the context of frailty. We have to filter every major decision, investigation, or treatment through the lens of 4 critical pragmatic questions. This is where clinical judgment truly replaces autopilot.
It is. The first question is always, does the patient want this?
So establishing their goals.
Absolutely. If the patient is frail, aggressive investigation aiming for life prolongation might cause unacceptable suffering. They may prioritize comfort and functional maintenance over a few extra months of life. We have to maximize their participation and document their values.
Okay, question 2. Will the investigation be feasible? Frailty dictates their tolerance limits.
It does. Can a patient with severe COPD and mild delirium tolerate the breath holding required for a CT scan? We have to weigh the risk of the process itself, the travel, the sedation, the fasting against the potential diagnostic gain.
Question 3. Will the investigation alter management? This is the ultimate cost-benefit analysis.
This is a powerful ethical filter. Let's say a patient with severe disabling dementia develops an abdominal mass. Investigating might confirm a malignancy, but if that patient is entirely unfit for surgery or chemo, does confirming the diagnosis change the palliative management?
Probably not.
Usually no. However, if that same patient develops dysphagia, investigating the cause does alter management. We might perform an endoscopy to ensure they can eat safely, which aligns with the goal of comfort. The test must lead to an achievable beneficial action.
And question 4. Will the management benefit the patient compared to standard guidelines? This is where we might intentionally undertreat based on population recommendations.
Exactly. Guidelines often target long-term outcomes. For the frail patient with limited life expectancy, those benefits may never materialize. Instead, we weigh the immediate quality of life. For instance, tight glycemic control carries a high risk of hypoglycemia, which causes falls and confusion.
So you might aim for a higher blood sugar target.
You might aim for a more relaxed target, prioritizing immediate safety and avoiding distressing blood tests over a distant theoretical benefit. Pragmatism must override rigid adherence.
And the need for these filters is amplified by the unique way illness presents in old age. Let's look at the 3 major clinical characteristics that mislead new clinicians.
First, late presentation. Older adults often minimize symptoms, thinking they're a normal part of aging, or their existing comorbidities mask new pain.
Right.
A patient with severe peripheral vascular disease might never feel angina because they can't walk far enough to induce it. We have to actively inquire.
Second, and the most dangerous characteristic, atypical presentation.
Classical features are so often absent. This is the hallmark of geriatric medicine. An infection, like a pneumonia, may present not with a cough and fever, but solely with delirium, a fall, or acute weakness. A heart attack may present only as breathlessness or malaise.
Why is that?
It's the blunted physiological response. They have altered pain perception, and their pyretic, their fever, response is dampened. You might see a temperature of 37.8 degrees C and dismiss it, but the source notes that a temperature over 38 degrees C in an older adult is often indicative of significant, important disease.
And the third characteristic, acute illness presenting as a simple change in function.
Patients or caregivers will often say they've gone off their feet or they're failing to cope. These are not diagnoses. They are descriptions of functional decline that should immediately trigger a comprehensive search for underlying acute precipitants, sepsis, electrolyte disturbances, dehydration, drug side effects.
So never ever accept failure to cope as the final diagnosis.
Never. And finally, always remember the rule of multiple pathology. A presentation is rarely due to a single cause. It's a culmination of factors.
Okay, we now move to the geriatric giants, the clinical syndromes identified by Sir Bernard Isaacs that signal underlying frailty. These are the major causes of morbidity and institutionalization.
Right, starting with falls and collapse or instability.
Falls are an absolute epidemic, aren't they?
They are. Affecting 30% of those over 65 annually, rising to over 40% of those over 80. A fall is defined as an unexpected event resulting in resting on the ground without a known loss of consciousness. But you have to remember, a fall is often a symptom of an acute illness.
And given the potential for amnesia after the syncopal event, the history has to be meticulously structured to separate a mechanical trip from a syncopal collapse.
This is where collateral history becomes so critical. We need to know if there was a known loss of consciousness, which is syncope, or if the patient tripped, slipped, or lost their balance.
And what are the mandatory investigations?
Due to the high risk of arrhythmias or orthostatic causes, every patient who falls requires a 12-lead ECG and a structured postural hypotension assessment.
The list of risk factors is enormous, but the single most addressable factor has to be medication.
It is. We must screen for the use of psychotropic medications, sleeping pills, benzodiazepines, some antidepressants, which impair balance and cognition.
And observing the gait is an invaluable zero-cost diagnostic tool. What are the key patterns we're looking for?
When you ask the patient to walk, look for these telltale signs. An antalgic gait, where they shorten the stance phase to minimize pain, suggesting arthropathy.
Oh.
A stamping gait, which occurs when they lose position sense and have to use exaggerated steps to feel the ground.
Like in a sensory neuropathy.
Exactly. Or shuffling festination, the classic short, speeding up steps of Parkinson's disease. And finally, marche à petits pas, or walk of small steps, which is often indicative of small vessel cerebrovascular disease.
For management, especially for recurrent fallers, what is the single most important intervention strategy?
It has to be multifactorial and multidisciplinary. You cannot treat falls with a single pill. Evidence-based interventions include, number 1, lower limb strength and balance training, things like Tai Chi.
Right.
Number 2, a home environment assessment by an OT. 3, medication deprescribing. And 4, sensory correction, like cataract surgery.
Okay, next giant. Dizziness.
Dizziness affects a huge portion of the older population, but it's challenging because patients really struggle to define the symptom. We have to impose a structure on the history.
So we anchor the differential diagnosis based on their subjective description. Let's review the 3 main symptom complexes.
First, presyncope or lightheadedness. This suggests impending faint, which points toward reduced cerebral perfusion. The most common cause is usually autonomic dysfunction leading to postural hypotension.
Second is vertigo.
The illusion of movement, the room spinning. This suggests a problem with the vestibular system. Peripheral causes are most common, but we have to exclude central lesions like a stroke if there are any brainstem signs.
And third.
Disequilibrium or unsteadiness. This is just a feeling of being off balance when walking. It suggests neurological or musculoskeletal problems, neuropathy, arthritis, Parkinson's.
Given that older adults usually have small deficits in all 3 areas, what's the key principle of managing dizziness?
The key principle is that dizziness is almost always multifactorial. You may not find one single definitive cause, But by treating 3 or 4 small contributing factors, optimizing vision, removing a sedative, you can achieve a large functional improvement.
The third giant, confusion covering delirium and dementia.
This is the central clinical challenge. Chronic cognitive decline, dementia, versus acute cognitive change, delirium. They commonly coexist, which leads to delirium superimposed on dementia, and that carries a very poor prognosis.
How do we spot pre-existing cognitive decline?
We rely on collateral history. The structured 88 interview for caregivers is essential. It asks about changes over the past year. Have they forgotten a recent major event? Have they struggled with complex tasks? A positive screen suggests established cognitive decline.
And focusing on delirium, the impact is terrifyingly high, up to 25% of all inpatients.
It is. Delirium is associated with increased mortality, institutionalization, and is a strong risk factor for subsequent permanent dementia.
How does a student recognize it, especially when it fluctuates so much?
It's defined by an acute onset and a hallmark fluctuating course. The defining neuropsychological feature is a deficit in attention. The patient just cannot hold focus.
And there are subtypes, right?
Yes, hyperactive, the agitated, restless patient, which is obvious, but also hypoactive, lethargic, sleepy, quiet. This is common in the frailest, often missed and associated with the highest mortality.
To diagnose it quickly, we use the 4AT.
Yes, the 4AT screens for alertness, the abbreviated mental test, and attention. A score of 4 or more indicates possible delirium. This should be used routinely whenever there's a change in status.
And management priority is not medication.
No, absolutely not. The first priority is prevention, using non-pharmacological strategies, sleep hygiene, early mobilization, hydration. And the second is treatment of the underlying precipitating factors.
So hunt for the cause.
Hunt for the cause. The common, seemingly trivial things: constipation, urinary retention, dehydration, pain, or a new drug. Antipsychotics are reserved only for situations where the patient is acutely distressed or a danger to themselves or others.
Fourth giant, incontinence.
Continence problems are common, but they are not an inevitable result of aging. New onset incontinence, especially, demands assessment as it frequently signals an acute illness.
And the management philosophy starts with the least invasive interventions.
Always. We start with lifestyle changes, weight loss, reducing caffeine, then bladder retraining and timed toileting. Containment with pads is a practical necessity, but catheterization is a last resort due to infection risk.
Briefly, what are the main types?
You have urgency incontinence from detrusor overactivity treated with bladder retraining, stress incontinence from a weak pelvic floor treated with pelvic floor muscle training, and overflow incontinence, often due to prostatic obstruction in men, which needs the obstruction addressed.
Okay, let's talk about infection in the older adult.
Infection risk is heightened due to a phenomenon called immunosenescence. The body's ability to mount an effective immune response just declines.
Plus, we layer on those anatomical changes we talked about. The impaired cough, the thinning skin, it's a perfect storm.
It is. And the diagnostic anchor must be the atypical presentation. We cannot wait for classic signs. The clinical presentation is often dominated by delirium and acute functional decline.
And no fever.
Often no fever because their baseline temperature is lower. So a high temperature, defined as above 38 degrees C, is a very serious sign in this population. If they present with a fall and confusion, you have to assume sepsis until proven otherwise.
And for management, the sources advise against just throwing broad-spectrum antibiotics at everyone.
Exactly. Unless the patient is clearly in septic shock, you should hold off, obtain cultures first, and then rationalize therapy based on sensitivity results. This helps reduce the risk of C. diff and antibiotic resistance.
Prevention is key.
Prevention through vaccination, flu, pneumococcus, zoster is non-negotiable, and meticulous infection control is crucial, especially in institutional settings.
The final geriatric giant, and maybe the most common, iatrogenic disease driven primarily by polypharmacy.
Yes, using 4 or more drugs. This is strongly associated with every poor outcome, from falls to hospitalization. The cause is often the complexity of care, with multiple specialists prescribing independently.
Which leads directly to the prescribing cascade.
The sources define this perfectly. A patient is put on drug A. Drug A causes side effect X. A new clinician fails to recognize X as a side effect and instead prescribes drug B to treat symptom X, and on it goes.
And the result is frequent, severe adverse drug reactions. Which drug classes are the biggest offenders?
We have to be extremely cautious with drugs that affect the CNS and fluid balance. NSAIDs, diuretics, opiates, and especially the centrally acting drugs. Benzodiazepines and drugs with strong anticholinergic properties. These are the key drivers of falls and delirium.
So polypharmacy is the disease, deprescribing is the cure.
It is. Deprescribing is a dynamic, systematic process that requires regular review. You often need controlled dose reduction to prevent withdrawal effects.
And we can use tools to help with this.
Yes, tools like Stop EP, which identifies potentially harmful prescriptions, and START, which identifies omissions of necessary treatment.
If you are making notes right now, focus on that one class of drugs we warned about. If an older patient presents with new onset confusion and a fracture, and they are taking a diuretic, a benzodiazepine, and an NSAI, which single drug class is the primary driver of both the confusion and the fall risk? The answer is the centrally acting agent, the benzodiazepine, causing cognitive impairment and balance issues. It is the first thing you look for.
Okay, that brings us to the end of our intensive deep dive into aging and disease.
Let's rapidly synthesize the essential anchors we've established from Davidson's for you, the future clinician. Number 1.
Focus on biological age, not chronological age. Assess functional capacity above all else. Aging means reduced functional reserve. Remember, the empty fuel tank of minor illness can cause catastrophic failure.
3.
Management requires comprehensive geriatric assessment, or CGA. It's the MDT pit stop, a dynamic, goal-driven, evidence-based process. A change in function or atypical presentation is often the first sign of acute illness. Never accept just age as a diagnosis.
And finally, number 5.
Prescribing in geriatrics is equally about deprescribing. Utilize tools like Stop PP and Start to Fight Polypharmacy and eliminate those high-risk, centrally acting drugs.
This chapter fundamentally changes how you view patient care, doesn't it? Moving from curing a single disease to managing a complex, vulnerable system.
It does. And that leads to our final provocative thought. We've seen that the coexistence of frailty and disability means function deteriorates markedly with even minor stress. This raises a crucial question for you as you enter practice.
What's that?
If we are highly effective at curing an acute life-threatening illness, performing a flawless surgery, or clearing a septic focus in a moderately frail individual, but we then fail to manage their underlying frailty and resulting disability post-event, have we actually prolonged their quality of life?
Or have we simply prolonged their trajectory toward dependency and institutionalization?
Exactly. We must prioritize the non-disease outcomes. The goal is not just survival, but achieving activity and participation, the true definition of functional health according to the WHO ICF.
Keep that focus on functional goals in every care decision you make. Until next time, keep diving deep into the material.